Assalamu alaikum. Hello everyone. My name is Dr. Komal Yaqoob and I'm PGR in Chemical Pathology department. Today my topic of presentation is a GAAD. It is an algorithm developed to aid in the early diagnosis and prognosis of hepatocellular carcinoma. If we talk about the global burden of hepatocellular carcinoma, it is the seventh most frequently occurring cancer worldwide, and it is the second leading cause of cancer mortality globally. The highest incidence rate in the world are found in Asia and Africa. Globally, the hepatocellular carcinoma is the dominant type of liver cancer, that is accounting for approximately 75% of the total. The late diagnosis result in the poor prognosis. So why we are speaking about the silent killer? Because hepatocellular carcinoma is often asymptomatic until advanced stages. When the 5-year survival rate drops to below 5%, and the early detection is crucial in high-risk groups, biannual screening has been shown to reduce the hepatocellular carcinoma mortality by 37%. When diagnosed at an early stage, the 5-year survival rate improves dramatically, about 40 to 70%. So, risk factors that are included for the hepatocellular carcinomas are viral infections like chronic hepatitis B and chronic hepatitis C, liver cirrhosis, alcoholic liver disease, non-alcoholic fatty liver disease, autoimmune hepatitis, primary biliary cholangitis, and hemochromatosis. Toxins and environmental factors, for example, aflatoxins B1 exposure, chronic alcoholic consumption, and smoking. The other, like metabolic and lifestyle factors, include diabetes mellitus, obesity, and metabolic syndromes. Chronic liver disease is a progressive liver damage from hepatitis B and C virus. Alcoholic, non-alcoholic steatohepatitis and persistent inflammation lead to the fibrosis and ultimately lead to the cirrhosis, which is a precancerous stage. 80 to 90% of the hepatocellular carcinoma cases occur in cirrhotic liver disease. The mechanism which include is chronic necroinflammation and genetic mutations that alter the cell regeneration, microenvironment promoting carcinogenesis. The clinical course include is early chronic liver disease, often asymptomatic or silent, and cirrhosis in portal hypertension and the liver failure. The transition to hepatocellular carcinoma include weight loss, jaundice, abdominal mass. Surveillance in the chronic liver disease patients enables early detection and improves the survival. This is the progression pathway of the liver disease leading toward the hepatocellular carcinoma. Like healthy liver is exposed to the different risk factors, and that will lead to the fatty changes, and that persistent fatty changes and inflammation lead to the fibrosis and liver cirrhosis that will ultimately advances to the hepatocellular carcinoma. Symptomatic hepatocellular carcinoma indicates advanced disease. By the time symptoms appear, disease is usually beyond curative stage. Curative options like surgical resection, liver transplantation, local ablations are rarely feasible. Patients are left with the palliative treatment like systemic therapy, transarterial chemoembolization, which offer limited the survival benefits. Early hepatocellular carcinoma diagnosis is the single most important factors influencing the long-term survival. So, surveillance in the high-risk population is cost-effective, life-saving, and guideline recommended. There are different biomarkers that are related to the hepatocellular carcinoma, like alpha-fetoprotein, which is a traditional and widely used biomarker, and often elevated in hepatocellular carcinoma, but with the limited sensitivity and specificity. And it can be raised in the chronic hepatitis and cirrhosis without cancer. PIVKA2, which is also known as des gamma carboxyprothrombin, it is a more specific for the hepatocellular carcinoma than alpha-fetoprotein, associated with the tumor progression and vascular invasion. Like combination or a biomarker panels using alpha-fetoprotein with the PIVKA2 improve the diagnostic accuracy to in either alone. Biomarker panels are beneficial for the early hepatocellular carcinoma detection and risk stratification in the cirrhotic patients. If we talk about the alpha-fetoprotein, it is an albumin-like glycoprotein and is synthesized during the fetal development by yolk sac, undifferentiated liver cells, and fetal gastrointestinal tract. Normally decreases rapidly after the birth and with very low levels in the healthy adults. Tumors that are associated with the alpha fetoprotein productions are hepatocellular carcinoma, non-seminomatous germ cell tumor of the testes, and yolk sac tumor of the ovary, occasionally in the other GI malignancies. PIVKA2 is an abnormal form of prothrombin. It is secreted in the bloodstream when vitamin K dependent carboxylate activity is impaired due to vitamin K deficiency, vitamin K antagonist, malignant hepatocytes such as in hepatocellular carcinoma. So, diagnostic role in the hepatocellular carcinoma is reported diagnostic accuracy about 59 to 84%, and more specific in distinguishing the hepatocellular carcinoma from the benign liver disease. Elevated PIVKA2 levels correlate with the tumor size, vascular invasion, and poor prognosis, increasingly used as complementary biomarker with the alpha fetoprotein. Current surveillance methods that are used is ultrasound liver biannually, and alpha fetoprotein measurement may be added. The rationale behind using this is that 6-month interval balances the tumor growth rate with early detection feasibility. Early diagnosis will lead to the higher chance of curative treatment and improve the survival rate. So there are some limitations of the ultrasound and alpha fetoprotein as well. Like ultrasound is operator dependent, poor in obese patient, and a meta-analysis found that ultrasound alone has only 45% sensitivity for detecting the early stage of hepatocellular carcinoma. Alpha fetoprotein that is elevated in the other disease like and has moderate sensitivity. CT and MRI are more sensitive but are less used for the surveillance due to higher cost, contrast use, and radiation exposure. So, what is GAAD? It is a multivariate index diagnostic algorithm that combines the demographic details like gender and age with the key biomarkers include alpha fetoprotein or DCP to generate a risk score from 0 to 10. So, purpose of a GAAD is early detection of hepatocellular carcinoma that aims to improve the diagnosis of early stage hepatocellular carcinoma in patients with chronic liver disease, risk stratification and prognosis. GAAD is indicated for the adults who has age greater than or equal to 18 years with the diagnosis of chronic liver disease and who are recommended for the hepatocellular carcinoma surveillance due to increased risk. The GAAD algorithm has only been validated in the adults and should not be applied to the pediatric population. So, it is a clinical workflow integration in which step 1, collect the blood sample, and step 2, run the AFP and PIVKA2. Then the results of AFP and PIVKA2 is with the demographic details like age and gender put into the data in online Navify GAAD calculator, and step 4 is interpret the score and guide the patient. It is the interpreting the GAAD score. It has cutoff value of 2.57. Less than 2.57 is considered as a negative results in which there is a low likelihood of hepatocellular carcinoma. And the second one is the continuous routine surveillance as a per guidelines. If it is equal or greater than 2.57, it is considered as a positive result. And there is an increased risk of hepatocellular carcinoma required for the further evaluation like imaging or diagnostic workup. In the journey of hepatocellular carcinoma, where GAAD help when we see or with in the start with the high risk population who may develop liver disease and later progress to cirrhosis and hepatocellular carcinoma. The standard approach is using alpha fetoprotein with or using ultrasound with or without alpha fetoprotein may miss the early cases. That's why GAAD improves this by diagnosis at earliest stage before cirrhosis or hepatocellular carcinoma develop. This is the graph showing the sensitivity of different modalities. Like alpha fetoprotein has 38% sensitivity, ultrasound 57% sensitivity, GAAD 73 sensitivity, and GAAD with the ultrasound conjunction, its sensitivity improves with the 88.5%. So this study shows that it is clinically validated over 1900 patients, and this algorithm can be used manually via a web tool or can be integrated into the automated system. And this graph shows the clinical performance of GAD as compared to the PIVCA and AFP alone. Like you can see the blue curve, which covers the maximum area under the curve, and that is occupied by the GAD. According to another study, this shows that GAD outperformed both AFP and PIVCA in terms of area under the curve. This graph shows that sensitivity of GAD at different stages of hepatocellular carcinoma. Like in all stages of the hepatocellular carcinoma, the sensitivity is about 77.4. In early stage, the sensitivity of GAD is 73. And in early stage of the carcinoma, the GAD with the ultrasound, the sensitivity improves about 85%. And in stage 1, the GAD with the ultrasound sensitivity improves from 89.5%. So it can be used as a prognostic biomarker in hepatocellular carcinoma. GAD also offers prognostic insight like correlate with the tumor burden and stage, helps to predict overall survival and disease progression. Like high GAD score indicate advanced hepatocellular carcinoma and a higher risk for poor outcomes and may require aggressive treatment and closer monitoring. Low GAD score suggests early stage disease with a better prognosis, and it is associated with the favorable treatment response and outcomes. So, what are the advantages of the GAD score? It is a non-invasive, rapid, and reliable, greater diagnostic yield with the ultrasound, and better performance in the early stages, useful in routine hepatocellular carcinoma surveillance. But there are limitations of this that GAD must be interpreted in conjunction with the other diagnostic findings and clinical information in accordance with the standard clinical management guidelines. Assays values must be determined from the same samples, like you have calculate the value of AFP and PIVCA on the same sample. The take-home message of this presentation is that hepatocellular carcinoma is often silent until advanced stages, when survival rates are extremely poor. Are critical, like 5-year survival improves from less than 5% in late disease to 40 to 70% when diagnosed early. Surveillance in high-risk patient is essential for timely diagnosis. AFP and PIVCA2 are the key biomarkers, and combinations outperform single markers. GAD algorithm provides superior diagnostic accuracy for the hepatocellular carcinoma. Biomarker-based surveillance enables curative treatment and improves the outcome. These are the references of my presentation. Thank you.